people join, I'll like introduce you and then you can like be in.
Perfect.
Yeah, it's just connecting to YouTube right now. All right, we should be live. Yeah, so we'll just give it a couple minutes. And then also you should be able to share your screen if you have a presentation or anything.
Yeah, I'll do that right now.
All right, perfect.
Do we have a time limit on Zoom or anything?
Not really. Like usually I'd say like keep it around like an hour. If it goes over, it's really fine. Like it doesn't matter. Or like under, doesn't really matter.
Okay.
Also really quick, how do you pronounce your name? I just don't want to mess it up.
You can call me Nick.
Okay, all right, perfect.
Yeah, my last name is Parisis.
Okay, Parisis, perfect, thank you. Okay, so we can go ahead and begin. Welcome everyone to today's shadowing session with Dr. Parisis. I hope I'm pronouncing it right. But it's so great to have you here today. Also, everyone, make sure to be posting your questions in the comments section, and he will answer them as well. So thank you so much for joining us today.
Well, thank you so much for having me. My name is Nick. I'm a PGY2 second year resident. I'm a radiology resident. So that means I've done one intern year and I'm starting my radiology residency now. And in this session, we'll be basically talking about the specialty of radiology, why I chose it, um, going over some clinical cases, and just kind of give you guys some of the basics about what radiology is and all that stuff. So before we start, feel free to follow me on Instagram and TikTok. This is my handle right here, just Dr. Parisis. And also subscribe to my YouTube channel, which I just started and just posted a video today about nailing the med school or residency interview. So we'll take it from there. And I think a good place to start is kind of where I'm from. And so I am from a small town outside of Northern California near Sacramento called Lodi, which is closer to a larger town called Stockton. So about basically 2 hours from the Bay Area or about 45 minutes from Sacramento. And I attended the University of California, Santa Cruz, which is about 2 hours west from my hometown. So at UC Santa Cruz, I played collegiate rugby. So I have rugby listed here as one of my hobbies, and I'm kind of repping banana slugs right now on my shirt. And in addition to that, I majored in molecular cell and developmental biology at UC Santa Cruz. So I took 2 gap years, so kind of used these 2 gap years to kind of get my application in line and kind of figure out how to apply to med school, line up all the things I needed to line up, as you guys are very familiar with, like personal statement, letters of rec, transcripts, et cetera, and so on. And I also worked at a startup in San Francisco called Augmetics, and this is a remote scribing startup. It's kind of a digital health startup. And I'm happy to talk more about that if you guys like. But I did do an Instagram post about it if you want to learn a little bit more about the company, because it is an interesting company. And so in that time, in those 2 years, I was basically working and applying to med school. And so the medical school that I decided to attend was LECOM in Bradenton, Florida, which is just outside the Tampa Bay area. So I did my first and second year at LECOM, so kind of preclinical book work. And then I did my 3rd and 4th year rotations in San Diego, California. And so I chose to go to LECOM because I knew I could possibly go back to San Diego for my rotation. So I did 3rd and 4th year there. And then I am currently at the University of Minnesota in Minneapolis in the Twin Cities for my radiology residency, which is 5 years long. So I did my first my first year of residency, which is an internship, and then I'm going to be here for my diagnostic radiology training and have some of my hobbies listed here for you. I also play traditional Greek folk music and post quite a bit on Instagram and YouTube these days. So social media is kind of a new hobby, if you will. So medical school is kind of like drinking from a fire hydrant. The only way to tame this beast, to manage this, is to come in like this guy and take in small sips each day and do that over and over and over. So it's just a large volume of information that comes at you super fast. And now that I'm starting radiology residency, it kind of feels like I'm drinking from the fire hydrant again. So it's kind of like starting med school all over again. Another analogy of medical school is it's kind of like eating a stack of pancakes for breakfast, lunch, and dinner Monday through Friday. Well, really Monday through Monday or whatever, 7 days a week, because you have to constantly come back to this information. You have to constantly relearn and refresh your anatomy, your pharmacology, your pathophysiology. And, we all love stacked pancakes for brunch on Saturday morning, once a week or once a month or whatever. But it can be very exhausting to come back to it over and over multiple times a day. So, med school is tough. So hang in there. We all get through it, and it's definitely possible to make it through. So just hang in there. But it's tough. So don't listen to anyone who says that it's easy. So there are a lot of misconceptions about what a radiologist is or what a radiologist does. So hopefully we'll address some of those today. So some people think we talk into some sort of broadcasting microphone, or they think we're like zombies that look at our computer. Or this is partially true. We do some minimally invasive surgeries, so kind of procedures, using images to kind of guide where we're going. And so some people think, some kids might think that we play video games. So we'll talk a little bit about all these misconceptions. So this is Mr. Wilhelm Röntgen, a German physicist. This is the very first X-ray of his wife's hand. So this is his wife here, and this is her wedding ring. So you can see how fuzzy it is. This was over 120 years ago, and this was the X-ray of his best friend's hand 3 weeks later. So you can see again the resolution. We'll compare this to what X-rays look like today. So just some brief history for you guys. So turn of the century here, we had X-rays being developed by Röntgen. Then we had ultrasounds come along, and ultrasounds are basically sound waves, or they're also called sonograms. Then we had the advent of CT and MRI, kind of about 40 years ago or so. And then X-rays went from film into digital form. Then the X-ray films went away, and we've kind of had this progression of more technology in the field of radiology, which is pretty cool. Now we have a lot of use of CT usage, especially in the emergency department. So it's a great tool. Some will say the physical exam has forever been lost, just because you can scan someone in the CT scanner and it has a lot of the answers that you can't get from examining a patient physically. And now we have kind of artificial intelligence, and we'll kind of wrap things up towards the end of this conversation, talking about AI and like, will AI take over radiology and take over the human race? So we'll kind of see where this will take us. So I'll start by talking about some of the medical aspects of the field. So this is kind of what our workstation looks like. Basically, when we are diagnosing disease and making calls, we are doing this on like a 4 or 5 monitor computer setup that are like super high resolution. They're like, I don't know, 4K or 8K or something. They cost like $15,000 each. And radiology is kind of the eye of medicine. So we're basically able to look into the body, which is super cool. So we use X-rays, CT scans, ultrasounds, and MRIs, as well as nuclear studies and fluoroscopy and many, many other modalities in order to look into the body and basically figure out what's going on and use this information of the anatomy and the pathology or the disease that we're seeing to make the diagnosis and treat disease by like doing procedures, and then also help the clinicians, help the surgeons who are on the front lines seeing patients, help them make decisions about patient care. So basically, we actually do a lot of procedures in radiology. I'll talk about some of them in some slides coming up. And we actually also see patients. So in breast radiology, for example, we actually have clinic. And a lot of people don't know this. A lot of people think that we just sit in the basement or in our swanky computer workstation and just look at X-rays basically all day long. And that's partially true. That's kind of the bread and butter of our job. But we actually do see patients. There are some subspecialties of radiology have a lot of patient care compared to others. Another thing we do in radiology is do what's called protocoling. So this is basically where we figure out if the doctor on the other end, the clinician or the surgeon, has ordered the correct study for what they're looking for. And did they order it correctly? Meaning, did it require contrast or is it better without contrast? So we do protocoling. We also learn how to treat contrast reactions. You guys may have heard of anaphylaxis with the COVID vaccine. Well, sometimes we give intravenous contrast to patients, and they may have an anaphylactic response to that, or have an allergic response where we do treat it with Benadryl, steroids, epinephrine, et cetera, and so on. It's very rare, but it does happen. So we also interact with the radiology technologists, and these are actually the people who are acquiring the images that we see on our computer screen. So these are the rads techs. And we also learn about radiation safety and physics. So this is something I think not a lot of people know either. So we actually have to command a large body of knowledge about physics. So in short, I think radiology, at least diagnostic radiology, is as close as you can get to a computer or desk job or tech job as you can within medicine. That said, a lot of doctors spend a lot of time at the computer, so this isn't all that uncommon, but at least we get a nice workstation is the way I look at it. So, this is a cartoon of this kid's, I don't know, parent or dad or whoever. You'll never amount to anything staring at that screen all day, playing who knows what, Nintendo here. And then, I'm so proud of you here that you made something of yourself and are not sitting at this screen, but now you're sitting at a different screen. So, just depends on kind of what you want out of life. And I thought this was a great workflow. So I don't view this as a bad thing necessarily. This is the radiologist asleep at home at night, and this is the radiologist at work during the day. So we actually do keep so it's not as bright as you see here in this bedroom. We actually dim the lights a little bit because this allows our eyes to perceive contrast on the images a little bit better. So it makes the images a little bit sharper, allows us to pick up things better, basically. So that's why we kind of dim the lights. And I thought that this would bother me at first, but it's actually quite nice. It's kind of, I don't know if you will, relaxing. It's not, it's not relaxing when you're making calls about emergent or urgent things, but it's not that bad. So this is kind of what a radiologist's day looks like. So this is the radiologist breakfast, working. We have lunch. Of course, you guys kind of get the idea. Driving, resting at home. So it's mostly at the computer, if you can imagine, and then throughout the day actually goes by pretty fast because the day is interrupted. So the day is interrupted by things like procedures. You might have as little as 1 or 2 procedures in a day, or up to, I don't know, 10 or so. You're also talking to patients, explaining them the procedure, what are the risks and benefits. And this is called consenting, where they sign a form so that they know the risks and benefits of, infection and bleeding and the risks of not doing the procedure, for example. We also do protocoling, which I talked about before. We also, I'm doing a lot of learning, but attendings and upper level residents will be doing a lot of teaching to lower level residents and med students. And as you can imagine, this takes time away from doing clinical work, like making diagnoses on the computer screen. And we also spend a lot of time on the phone. So the phone will go off, and we'll have to pick it up and see what the issue is, and kind of help clear things up. So sometimes a radiology technologist might have questions, or a clinician might have a question, or they may have a request, like they want us to read a certain study faster or something. And sometimes teams come in with their, like the entire, pediatrics team will come into the room and want to talk about a certain case. So it could be on the phone, could be in person. And then, of course, if you have any downtime, probably not, in your clinical workday, you could spend that time doing research, and then again, depending on your specialty, going to clinic. So I think breast imaging and interventional radiology are the 2 subspecialties within radiology that actually have clinic, in case you enjoy that or find that you don't enjoy that. These are the daily activities of the kind of general medical doctor. So, we all go into medicine because we want this. We want patient care. But we spend a lot of time, half of our time, doing this, which is not patient care. And then we spend a lot of time in the hospital doing this, which is not medicine. It's like ordering scans and waiting for the patient to transfer, and waiting for recommendations from consultants. And radiology is a little bit different from this, because this is the hours per week radiologists spend on paperwork and administration. So there's no way to really get around this in medicine these days, but you can see some of the other specialties that rank lower on this list. And I just really wasn't that interested in doing things like calling the insurance company, being on the phone with the pharmacist or the pharmacy, doing paperwork for insurance companies and billing and this and that. I was more interested in the actual core of medicine of, calling, kind of making decisions about patients. So this is a huge positive for me. Okay, so why radiology? So I have quite a few reasons listed here, and we'll go through them kind of systematically. So here we have a picture of a mammogram. This is probably a breast imaging radiologist, and mammograms are done to screen for breast cancer. This doesn't look very good here. I would want to follow that up with an ultrasound or likely biopsy, depending on what's been done already. So why radiology? So the first and most important reason, I think, is because the radiology report, it actually has a direct impact on what happens with the patient. So if you can imagine, if you make a certain call, then that will change whether a patient has surgery or not, or is on a certain chemotherapy regimen or not, or if a patient's treated with physical therapy versus something more aggressive. So the radiology report really matters. It's an objective metric for managing a patient's care. If you want to think about it from a public health perspective, you actually see more patients in a day as a radiologist than you do as probably any other type of doctor. I don't know in pathology how many specimens they look at. But if you're reading, let's say, 100 scans a day, or even 50, which would be very low. It could be up to 150 scans per day. Then that's 100 different people that you're helping per day. As a surgeon, maybe you can do, I don't know, 5 or 10 surgeries in a day, or see 20 or 30 patients in the clinic if you're in primary care. So I thought this was pretty cool. You can have a really big impact on someone's life. Basically, someone can get the care that they need. Like get their fracture fixed, or get the hip implant that they need, et cetera, and so on. You kind of get the idea. Get their stroke treated. So another reason, which I alluded to before, was that there's not so much paperwork and bureaucracy, and we kind of focus on the anatomy and the pathology. So we don't spend a lot of time, placing orders and reviewing the chart and dealing with insurance companies and fighting with the, social work and disposition and where's this patient going to go, and kind of coordinating their care. So if you enjoy that, then that's great, but I personally did not. Another reason why I chose it was because I wanted to be a generalist and a specialist at the same time. So I really enjoy how we kind of cover the body from top to bottom with imaging. So that kind of makes us a generalist. And I also enjoyed it because we're also specialists at the imaging level. So we kind of hold the grip on the domain of imaging in medicine. So big breadth, a lot of diversity. I'll talk about the fellowships that we're able to do within radiology. And because of this, we actually have a lot of rare diagnoses that we see that come through, partly because we see more patients in a day. And the patients that we see are often very, very sick. The patients in the hospital that are very complex and very sick and have very rare diagnoses often have had these diagnoses made with the help of imaging. So I think that makes it for a very interesting specialty. Another thing that makes it very interesting is AI. Some people think AI will take over radiology, and we'll talk about that later. So I think in general we have like pretty cool tech. It's very innovative, kind of a cutting edge specialty. Another thing I liked about radiology is that there's a huge emphasis on teaching and research, and because of this, because of the mountain of knowledge that there is to know as an attending radiologist, there's a lot of studying to do, a lot of studying. Boards are very difficult, but you kind of learn through osmosis, as I'm doing now at the beginning of my radiology residency. So there's no way to cram all this information. This is someone I guess trying to cram a bed into a small car. This is the same idea. You can't fit, years worth of knowledge into a couple weeks. It's just not possible. So yeah. So if you ask a radiologist, would you pick the same specialty? I think we did pretty good. We did pretty good here. So this is kind of job satisfaction is the way I look at it. No job is perfect. Just know that now. No job is perfect. Yeah, I mean, I don't know. People will talk about dermatology, I guess. But I think we did pretty good. And yeah, I'll let you do with this information what you like. All these charts that kind of look like this with the blue, they're from Medscape, kind of a huge kind of pool of physicians who decided to participate. So this is a pretty good sample size. I think it's, tens of thousands of doctors who participated. So similar to this is from 2018, kind of the pain scale, kind of in a cartoon format. How would you rate your pain on a scale from orthopedics to nephrology? So orthopedics is here, plastic surgery, and then we see radiology kind of up here as well. So I think consistently radiology does pretty well. It's not perfect, but I think we do pretty well as far as satisfaction. So why radiology? So, okay, let's keep going with this. So I noticed that people would switch into radiology from other specialties. People would come in from general surgery, vascular surgery, ortho, all sorts of surgical specialties, as well as specialties like psychiatry and internal medicine. But then once people got to radiology, generally they would not leave the specialty. It's not to say that people don't leave the specialty of radiology, but I think in general it's less common. I noticed this on my residency interviews. I was like, oh, this is pretty interesting that people are like jumping ship kind of during their residency and like trying to pursue a whole different specialty path, because you basically have to start over when you do that. You'll kind of figure out for yourself in medical school whether you are a thinker. Like, do you like to work with your mind? Do you like to work with your hands more? Do you like doing both? And whether you would like to work with your hands more, or if you want to work with your mind more. And so in radiology, we kind of, I think where we strive, we have a lot of flexibility for you to only work with your mind, or primarily work with your mind, or to do a lot of procedures, like 90% of the time doing procedures, or to kind of have a mix of both. So I think it's pretty cool. Generally, the reading room is a kind of lower stress, not super noisy, kind of more relaxed environment. And generally, the people in there, your colleagues, are kind of more chill and laid back and humble. Not a huge ego. So, if you want to be like the cowboy doctor who's like doing crazy stuff, like, I don't know, on the front lines, like getting your hands bloody and stuff, probably not the specialty for you. But I think we have a pretty good group in radiology. People are like chill, smart. Yeah, some people are nerdy. Some people are more social than others, and there's people kind of in the middle. So I think I think we have something to offer for almost everyone. Um, I talked about this earlier a little bit. Imaging is kind of the physical exam of the 21st century. So sometimes you just like need to do some imaging to make sure. So I don't know, this cartoon of this doctor talking to the skeleton. Uh, let's just do an X-ray to make sure. So um, in med school, you learn that history and physical exam is extremely important, and it's still extremely important in residency and as an attending. But sometimes you just got to put them in the CT scanner, the donut of truth, because this will have the answers that you can't see with your eyes or feel with your hands or hear with your stethoscope. And oftentimes, patients can't participate in the physical exam because they're sedated, obtunded, they have a breathing tube in, altered mental status. You can kind of imagine the reasons why they wouldn't be able to participate. In med school, we're taught a lot about the physical exam techniques. And as I learned about them in med school, I was like, oh, some of these are like not super sensitive or specific. And in real practice, I mean, imaging is much more accurate to make a hard call. And even imaging isn't 100% all the time, but I found that it's much better. I don't know. It's just a more accurate way of going about making diagnoses with imaging than it was with doing a physical exam. So, okay, more reasons. So I talked about flexibility earlier. We have a lot of fellowship options. I'll talk about them coming up. And so because of this, you can have a lot of patient interaction and procedures as you want, or you can kind of dial that back and not have as much. You're kind of in this position of the doctor's doctor, and a lot of other specialties will call themselves this. So that's okay. It's not super specific to radiology, but in a sense, we are consultants for medical imaging, and we get consulted basically every day, which is pretty cool. I think now with the pandemic, working remotely, doing reading your X-rays in your underwear from home is going to be much more desirable. There are downsides to teleradiology from working from home, but I think it's, of all the medical specialties, it probably lends itself the best to a computer or desk job. And that's not to say that that's right for everyone, but some people do want to leave their home and go to the hospital or to the office. And some people want a mix of both, where they do 3 days of one and then 2 of the other. So again, flexibility, I think, is where we really strive. In addition to that, I'd be remiss if I didn't talk about work-life balance and career longevity, because you want to think to yourself, what can I do for 30 years? What can I do for 30 years and not get burnt out 20 years in or 15 years in? Because us as physicians, we have a shorter work cycle to save for retirement and for investments and stuff like that. And you don't want to burn out too quickly, right? You want to have some semblance of balance. And you'll figure this out for yourself in med school, what you can do, what you can stomach until you're 60 or 65. But even, let's say you are 65, you're working hard until 65, then what could you do for another 5 or 10 years if you had to work longer for retirement? Like, I think I could do radiology into my older years, and I don't know if I could be doing surgery, after 60 or 65. So yeah, hopefully you kind of get what I'm saying. All right, so the last reason I have here is that, generally speaking, this is Jim here from the office, of course, radiology is shift work. So you do your 8 or 9 or 10 or 12-hour shift, and then you're done. So you don't take work home with you, which is super nice. So there are other specialties like anesthesiology and emergency medicine, which also have shift work. And call works a little bit different in radiology. So interventional radiology is kind of the exception to this, where they take a lot more call than the other more diagnostic specialties. So I think this it's nice because radiology is more of a task-oriented job where you're focusing on one study or one image at a time, and then you move on to the next thing. So this is the emergency doctor, or like a Squidward, asking for a scan, I don't know, CT scan of some sort of patient, and the minute before your shift is done. And the beauty of radiology is, like, let's say it's an X-ray. It might take you 5 minutes to look at it and then move on. And so you're not stuck at the hospital like way beyond past your shift. So it's a little bit different than having like a whole patient to work up like 30 minutes before your shift is done, and then you're there. You're done at 7 o'clock, and then you're there until 10 o'clock at night. So it's a little different. So that's shift work. All right, so you're probably wondering, okay, what about malpractice, and how many scans per shift, and how many hours are these people working? So to preface this, so everyone misses things. So radiology is not 100%. Malpractice is not 0, but you will miss things, and that's okay. And in residency, that's how we learn. Actually, we miss things, and then we go over that with the attending. So I think malpractice is not as bad as other fields like plastic surgery and OBGYN, but it's not as low as, I don't know what the lowest specialty would be. Maybe family medicine. Someone can maybe correct me in the chat here, or like Google it real quick. So if you're reading, let's say 100 scans per shift, let's say it's like a 9 or 10 hour shift, that will be probably a mix of X-rays, ultrasounds, CTs, and MRI scans, as well as maybe a handful of procedures throughout the day. The hours that you're working, it would not be uncommon to work actually more hours as a attending than as a resident. So as a resident, you're probably working 45 to 55 hours a week, and as an attending, you're probably working 50 to 55. So it's manageable. And then in addition to that, you have call. So call is basically, it's not like you're at home and then your pager goes off. You're actually at work. Like, you have the computer on, you're mentally on, and like you are the radiologist who's like on call, and you're making the shots. You're calling the shots basically. So call is basically anything outside of banker's hours, outside of 7:30 to 4:30. So kind of regular hours are 8 to 5 or 7:30 to 4:30, Monday through Friday. And so call would be like an evening shift, an overnight shift, or a weekend shift. So if you're working those and you're taking call, it would not be uncommon to have to take call as an attending, but not all attending jobs have you take call. And oftentimes you'll make more money if you do take call, or you can sell your call if you don't need it, for example. Vacation, it wouldn't be uncommon to have at least 6 to 7 weeks of vacation. And I mean, we had a lecture today about the business of radiology, and there are some jobs where you will have 12 weeks of vacation or up to 16. If you really want to go super rural and have a really swanky gig, the salary will be much higher the more rural you go. So salary is higher rural, and salary is lower if you go urban. It's not to say the salary is bad in more urban environments. It's just more competitive, and supply and demand, just how economics of healthcare kind of works, or the economics of physicians works. In private practice, most radiologists actually work in private practice. I forget if it's 60% or 90% of radiologists working in private practice. And then about 10 to 20% work in academics. So academics means like a university center, like the University of Minnesota here, your UCSFs and Harvards, and MSUs and whatnot. And generally, as an academic radiologist, you are only reading what you are fellowship trained in. So you might be only reading neuroradiology or musculoskeletal radiology, if that's your fellowship. In private practice, you are doing maybe 25 to 50% of the time what you're fellowship trained in, but you're also helping with general work. So you might be helping out with like breast imaging, like mammograms, and doing some biopsies, in addition to reading plain films like radiographs and x-rays, and some basic ultrasounds and stuff like that. So it's a little bit more general in the community. So how many weeks of vacation do radiologists take? It would be very uncommon to have less than 2 weeks, for example, and then it would not be uncommon to have more than 6 weeks, really up to like 12 or 16 if you can really land like a really solid gig. Do radiologists feel fairly compensated? Again, this is data from the Medscape survey. I think we do pretty good here. I'll let you look at this list in more detail if you want to compare other specialties. But again, I think we do pretty good. And then you can look up the actual salaries depending on geography, because it does vary widely, West Coast, East Coast, urban, rural, metropolitan, not metropolitan. So just to kind of get an idea of how much money you might expect to make as a radiologist. So this patient is saying, I'm wise, I see you, you're the med student, am I to see one, do one, or teach one case? This is kind of a saying in medicine. You kind of see one, and then you do one, and then you teach it. Or it's more like you do a couple or a handful, or like 10 or so, and then you're able to kind of teach it. So radiologists do a lot of procedures. This is a super cool aspect of our specialty, I think. The types of procedures that you'll primarily be doing depends on your fellowship. So I have some of the fellowships listed out here for you. This is not the list of all the fellowships, but as a muscles and bones radiologist, then you might be doing things like hip or joint injections, where you're using a needle and an x-ray to guide that needle and put a little bit of steroids in a patient's joint in order to alleviate their pain. You'll also learn how to do bone biopsies, where you basically take a sample of the bone and send it off to the lab, and they will tell us if it's cancer or not. As a neuroradiologist, you might be doing something called a lumbar puncture, basically putting a needle in the spine, getting some cerebral spinal fluid or some brain fluid, sending it off to the lab, and then we can kind of analyze it for infection versus inflammation versus hemorrhagic etiology or whatever's going on with the patient. So again, you're using basically fluoroscopy or x-rays to guide your needle to get a sample of cerebral spinal fluid. If you're a pediatric radiologist, so you might be doing something called the intussusception reduction. What that is, basically, it's when the bowel kind of telescopes on itself. It kind of gets twisted, and if you can imagine, kind of does this. And that's actually an emergency. So a radiologist gets called when that happens. And we can see this on an ultrasound, for example. So a radiologist comes in and does an intussusception reduction. And we do this by using a air contrast enema. So the procedure that we have to be on call for. As an abdominal or body radiologist, you might be placing a CT scan guided abscess drain. It's basically putting a tube where a collection of pus or infection is, like an abscess, and then you drain it. And then the patient has the drain over a period of days to weeks, depending on how the abscess is doing. Body radiologists also do a lot of other CT guided procedures. Super cool specialty. In breast imaging, I just finished a month of breast imaging. So we'll do all sorts of biopsies of the breast. Typically, as you can imagine, to look for breast cancer, but oftentimes it is a benign etiology, like a benign cyst or fibroadenoma. And so we use ultrasounds to do ultrasound guided biopsies if there's a palpable lump. If we can't feel it, if it's not palpable, then if we see calcifications on the mammogram, which is an x-ray, so we might see like little speckles of white calcifications, then we could do an x-ray guided or mammographic guided biopsy, and that's called a stereotactic biopsy. We also do MRI guided biopsies for other lesions that are even more difficult to access. In interventional radiology, they do over 200 different procedures. I don't know of a surgical specialty that even matches this. Yeah, you're not doing like, open heart or open abdominal surgery, but I mean, there's so much variety. I mean, the sky's the limit with interventional radiology. Super cool specialty. I'll refrain from going through all of these procedures here, but you can look them up on your own time if you want to kind of get an idea of what they do. It's really hard to understand what they're doing because it's such an advanced specialty. And follow my Instagram for more information about interventional radiology, because I'll be doing that in about 3.5 weeks, and I'll likely be posting a lot more clinical cases and around then. And so the reason to do IR is because of procedures, but the reason not to do it is for the same reason, because you're on your feet for, 8 hours a day, and you're wearing a lead-lined scrub cap, you're wearing a lead-lined goggles, as well as a mask and a thyroid shield and a lead shirt and a lead skirt to protect your reproductive organs, of course. And it can be kind of physically exhausting. So if that's what you want, then that's great. But if it's not, that's okay too. And there are other specialties that still give you a little bit of procedures and not 90% of the time procedures. And there are some jobs where you are an interventional radiologist, like fellowship trained, 100% IR doctor, but then you're only doing 70% actual IR, and then you're doing 30% of the time diagnostic work. So it's pretty nice setup there. Okay, so residency. So maybe one negative to radiology is how long residency is. So it is 6 to 7 years after med school, or 14 to 15 years after high school. So your first year of residency after med school is called your internship or your intern year. There's transitional years, internal medicine years, and surgical years. I did a transitional year. This is kind of a blend of medicine and surgery. Then the next 4 are diagnostic radiology, and then typically your last year will be fellowship. These are the fellowships, musculoskeletal, neuro, body, breast, pediatrics. Nuclear medicine is a subspecialty of radiology. I talked about IR. There's also a neuro IR or neurointerventional. This is a 2-year fellowship, so this one takes a little bit longer. There are multiple paths that get to IR. I won't talk about them here today. And yeah, it's quite the road. But you basically go through the match, and then you match into a residency program. This crazy process. And I did my internship at Hennepin County Medical Center, and then I'm currently a University of Minnesota employee as a diagnostic radiology resident. So hope that helps color your guys' understanding of kind of the training path. Takes a long time, but for a good reason. I think there's a lot to know. This is kind of how learning in the reading room might work in residency. So your attending will be like, hey, do you want to staff out and kind of talk about, I don't know, 5 or 10 x-rays or something? And they'll be like, oh, good job on that report. I really agree with what you said. You're like, oh, thank you, Dr. Rad. And then they're going to make some minor changes and then finalize it. And then they'll say, delete that, change this, and kind of change the report. And you'll kind of see kind of what you miss and what mistakes you make, and then internalize that knowledge moving forward. So this is just how we learn. And so it can feel kind of tough there because of the mountain of knowledge that we need to know. It could just, radiology residency is tough, but for different reasons than other residencies. So, okay, what about AI? So this is Dr. Cellini, interventional radiologist, now in attending. Great YouTube video here about will AI basically replace our job? The answer is no. So if you want to stop listening now, go for it. But people have been talking about AI replacing the doctor since, I think, 1976. There's like a New England Journal of Medicine article that talked about how a algorithm will replace the hospital doctor or the hospitalist or the internist because of, I don't know, all they do is kind of interpret objective data metrics of the patient. And that's not, all they do. It's kind of a reductionist approach. But AI is a very exciting field. I think lately we've come to a place where it's like actually legit. But there are a lot of hurdles before we actually adopt it. I won't go over all of these. I've just listed some of them here for you guys to think about. Humans are inherently biased. Every algorithm that we build is going to be biased. It's going to have bias built into it. But if you ask the tech people, how are we going to correct this? Well, their answer is we can build an algorithm to correct for the bias. So you can see where kind of the AI algorithm is going to be both the savior and the boogeyman, and just kind of funny circular logic. You can't ask the algorithm, explain yourself, like how did you come to your conclusion? There's no explainability. It's kind of a black box phenomenon. These algorithms need to be reproducible, just like any other scientific process, scientific method. Reproducibility is super important. Who's going to oversee it? Software, inevitably glitches and gets hacked, and how's it going to be implemented in the current software that we're using? Who owns the data? Is it the patient? Is it the tech company who sold us the algorithm? Is it the hospital? Is it the radiologist? Probably not the radiologist, but and then not everything that the AI algorithm is going to pick up, just because it can, quote unquote, see more pixels or more voxels, doesn't mean that it's clinically relevant. So that doesn't, it won't always make an impact for the patient's management or their care, surgery or not surgery, medicine or not medicine. Is this patient going home, or are they going to stay in the hospital? So just because you can see more isn't always a good thing. Context is very important. And yeah, I'll kind of leave it at there. So there are other way lower hanging fruit for AI to take over. So scheduling, Why not? Why don't we just start with scheduling? No one wants to do scheduling. Triaging studies. There's actually an AI algorithm startup in Israel that got valued pretty highly. I think 65 million or so. And basically, what it's going to be doing is triaging studies for emergency departments. So let's say an emergency department radiologist or emergency radiologist is super backed up and backlogged. They have 50 studies that they need to get through, and there's only 2 of them or 3 of them trying to get through the work. The algorithm can basically kind of pre-scan the list and then flag something that it thinks that is imminently life-threatening, and then kind of notify the radiologist so that they could read it, kind of next, or like stat. So that's pretty cool. So far, the application uses are extremely narrow. So, one AI will be only good for kidney stones or pneumonias or pneumothorax. So you also want to think about, like, what would your mom want? What would your dad want, or your brother and sister? What would a patient want? Would they trust this? So basically, I think where I'll leave things is that AI will supplement the radiologist to improve patient outcomes, and it's not going to replace the radiologist. Basically, the practice of radiology will likely look very different at the end of my career than it will, probably the beginning of your career or the way it does today. So it will look very different in the future. Robot is saying here, I'm being sued for a misdiagnosis. What do I do now? Sorry, buddy, comes with the job. So it sounds very appealing to hand over radiology to AI, but there are other things that we have to think about. What if it misses something? Whose head is on the chopping block? Okay, so I think we've addressed some of these misconceptions here. We're not all socially awkward introverts, antisocial. There is patient care. Reading imaging, as you'll soon see, is actually very difficult. And I didn't talk much about this earlier, but not all scans have ionizing radiation. So ionizing radiation is cancer-causing radiation. So ultrasounds and MRI scanners do not have ionizing radiation. X-rays and CT scans do. Now, X-rays have about the same amount of radiation as you would get from flying from New York City to San Francisco 3 times, there, back, and back again. CT scans have anywhere from 10 to 100 times that amount of radiation. So it's a considerable amount. But again, it's all risks and benefits, and it's all, context is very important. And then we talked about how AI will likely not replace the radiologist. So as you can see here, this is a radiologist with his psychologist. You and I aren't that different, Doc. We both see right through people. So all right, I'll stop here and take some questions, kind of check the time. And looks like there are quite a few messages here. Okay, so let's start with the first one. What is the most common medical imaging technique used by radiologists? I think we talked about that. Probably X-rays are probably the most common. Ultrasounds are also very common. CT scans are very, very common. And I think where radiologists really earn their stripes, so to speak, is with MRIs. MRIs are very challenging to read. Next question is, how much do radiologists typically interact with patients? It depends on your specialty. You might have, 2 patients in a day, or you might have 10 or 15 or 20 if you have clinics, so it depends. Do they simply read and analyze scans and images, or do they also communicate with patients and perform medical procedures? Well, I think we've talked a little bit about this now. They clearly perform medical procedures and communicate with patients for sure. It's funny because sometimes patients don't always know that a radiologist is actually a physician and that they went to med school. So a lot of misconceptions. Hopefully we've addressed some of them here. In terms of technology, what does the future of radiology look like? Hopefully we've touched on that with my slide on AI. The future, I think, looks good. Who wouldn't want an AI algorithm to take over their job and basically just send them a report and then I can just sign off on it? I mean, how nice is that, right? It's basically like having like a resident do your work for you. Kind of half joking there, but I think the future of radiology will look very different than how it is practiced today. Next question: what do you think is the biggest challenge in the field of radiology today? Probably the biggest challenge is just like people don't know what a radiologist is, and so or what a radiologist does. And so there are a lot of misconceptions, like I talked about, and in the kind of the eye of the public, people just don't understand. Like, people understand kind of what a surgeon does and what a cardiologist does, but there is kind of from the eye of the public, I think that is a challenge in the field of radiology, because we do interact with patients and we have to talk to them about their breast cancer diagnosis, et cetera, and so on. So I think it's important for patients to know kind of where we lie in the healthcare team. Can a frequent amount of little radiation harm the body over time? Can radiologists rely on medical imaging? I don't quite understand this, but yes, medical imaging is reliable. Radiation can harm the body. I talked about kind of ionizing versus non-ionizing radiation. Basically, it's a non-issue with ultrasounds and MRI scans. But again, it's all risks and benefits, pros and cons. And there's you learn about radiation safety in residency, so I wouldn't worry about this right now. We kind of get education on this about like how much, like what dose of radiation is acceptable for an employee who interacts with radiation on a daily basis, like a radiology technologist or a technician or a radiologist. Next question is, what is the most important skill you find yourself using on a day-to-day basis that you didn't necessarily think you would before you started? Oh, that's a tough one. Well, skills, there's procedural skills. So there's no way to actually get in all of these procedural skills in radiology as a medical student. So you're learning a lot of procedural skills, which I think is pretty cool. And then there's more like technical analytical skills, which are kind of harder to describe. And so, yeah, radiology residency is like starting medical school all over again. It's just a whole different beast. What type of machine do you use most as a radiologist? Well, the technologists are actually acquiring the images. They're the ones taking the patient to the CT scanner or the MRI scanner, or doing the ultrasound with the ultrasound probe. But the machines that we probably use the most often is probably an ultrasound probe or a fluoroscopy machine, which is like a live X-ray machine. All right. Next question. As new technology is introduced to the world as we speak, what implications do you think these new technologies will have on the field of radiology? I think it will make diagnostics more accurate than ever before, my personal opinion. And I talked a little about AI before. Is the field of radiology moving more towards patient interaction? Great question. I think the answer to this is definitely yes. Definitely yes. So that's a good question. Are there any subspecialties that are popular? What are some new technologies in the radiology world that you think will create a lot of change? So I talked about some of the technologies. Are there subspecialties that are popular? Yes. Neuroradiology is very popular, and so is musculoskeletal radiology, because they are difficult to master. And so if you want to feel very comfortable reading those modalities in practice, then it would make sense to do a fellowship. Also, breast imaging is generally very popular. It's a great field. You do a lot of procedures, again, patient interaction, good amount of diagnostics as well. And the job market is always very, very good. So the lifestyle is very good. You basically work banker's hours Monday through Friday, no emergencies, no weekends, no call, and no nights. So pretty nice. Breast imaging is pretty nice. Interventional radiology is very popular just because of the sheer amount of cool procedures that they do. Just such a cool specialty. I don't know if body imaging it's still pretty popular subspecialty. I think pediatrics and nuclear medicine are probably the least popular subspecialties in radiology. Next question: what are the pros and cons of being a radiologist? I think I've talked about a little bit about this in this presentation. The major cons are like how long it takes, and I think that's it for me, anyways. Just because there's all these pros of flexibility. You can have your life, you can kind of craft your life in so many different ways. Like if you're tired of being at a large academic center, then you can go into private practice and make more money and work harder potentially. Or even then, there's other private practice jobs that have like flexibility within like how much you want to work or how little you want to work, et cetera, and so on. Or like, do you want to mostly be doing teaching and research? And so we have quite a lot of variety to offer, I think. And then again, rural versus urban. Are you going to be more? Do you want to only read what you're fellowship trained in, or do you want to be more of a generalist? Just depends what you want. What is the most rewarding thing about your job? Well, I'm just a resident now, so I'm still learning. I think the most rewarding thing is just like making a diagnosis, and like you're the person who made that call, and then you know that that patient will get the care that they need based on your report. Like they'll get their fracture fixed or their cancer treated, et cetera, and so on. So, okay, there are a lot of questions here, so I'm going to move on to some cases and probably just zip through all these cases so we can get through some of these questions. Keep dropping your questions here in the chat, and we'll get started here with some actual radiology or some kind of Barney Basics radiology, just because, of course, I'm still a learner as well. So this is a chest x-ray. You can see all the anatomy listed here. Fantastic Instagram page here, the radiologist. Just to get oriented, this is the left side, and this is the right side. And that's just kind of the orientation in radiology. The basic anatomy here is listed for you. In radiology, when we say something is lucent, then that means it's black. So it's more filled with air. As you can imagine, the lungs sit here on the left and on the right, and the heart sits in the middle. And we have the bones here, which are more dense. So things that are opaque or more white, like the diaphragm here, or the liver would sit here, right, on the right side. And bones, of course, like the scapula and the clavicle, those are more opaque or white because they're more dense. So air is less dense. So another fantastic Instagram page is a radiology guy here. Also follow my Instagram if you aren't already. And this is more anatomy just kind of overlaid on top of the chest x-ray. So in addition to what we see here, we have a lot of this kind of underlying anatomy here. You can see all of the anatomy of the heart, as well as some gastrointestinal anatomy down here. This is a CT scan. This is a little different. So this is, again, this is the anatomy of the chest. So this is in a coronal plane. So if you can imagine this blue slice cutting through the patient here, cutting through. And then we also have kind of cross-sectional transverse planes, which kind of you can scroll up and down through a body, or you can scroll kind of forwards and backwards, or side to side through the body. So these are just different anatomical planes. If you don't understand this, that's all good. You will learn about this in med school. Again, much of the same anatomy that we see in these chest x-rays. So first case, so 65-year-old female, history of chronic obstructive pulmonary disease, presents with a fever, shortness of breath, and hacking up sputum that's green in color. This patient might be a smoker. They have pleuritic chest pain, so whenever they take a big, deep breath in, when they inspire, they have chest pain. They also present with tachypnea, so this is breathing fast, so elevated respiratory rate, as well as tachycardia, which means that their heart rate is elevated or their heart is beating fast. And they have crackles or leukocytosis. So crackles is basically when you put the stethoscope on the patient's lungs and you hear kind of this crackling, popping sounds. If you order some labs, like some blood work, then on a complete blood count, a CBC, you might see a leukocytosis, which is an elevation in the leukocytes or the white blood cells. And typically that's an infection, a marker of infection. So the differential here would primarily include infection. And as you can imagine, with something like a respiratory complaint in a smoker and someone with lung disease who's presenting with a fever, and this focal kind of consolidation on a chest x-ray, this would be a right lower lobe. So the lung has different lobes. This is an opacity because it's more dense. It's radiopaque. This is a pneumonia. This is all consistent with a bacterial pneumonia. So this patient is probably going to be treated with intravenous antibiotics and admitted to the hospital. Speaking of pneumonia, this is a COVID pneumonia. This is a chest CT, and some of the findings that we see in a COVID pneumonia. So here we see some consolidation. You see some of the basic anatomy here, and then you see also some schmutz or some junkiness in the lungs that should not be here. This should not be here. You see these peripheral ground glass opacities, and these blood vessels are kind of dilated. So this is called vascular dilation. You also see some other findings in COVID pneumonia, like crazy paving, which I'll not talk about in this lecture. All right, next case. So 58-year-old male, pretty noisy or pretty busy chest x-ray here. So this patient has a history of coronary artery disease or heart disease. Maybe they're a smoker, maybe they're diabetic as well. They present with shortness of breath, not the other SOB, as well as orthopnea. And this means that they have difficulty breathing when they're laying backwards or laying flat. And so they are requiring pillows on the back of their, kind of to sit themselves up, and this provides them relief of their shortness of breath. So that's called orthopnea. They also have tachypnea, so their breathing, their respiratory rate is fast, so 30 breaths per minute. That would be pretty fast. Anything over 20 or 24 would be pretty fast breathing. Their oxygen saturation might be a little low, so this is 90%. Not the worst, but definitely not the best. I'd probably want to give this patient some oxygen. This patient also has rales. So rales are kind of these high-pitched whistling sounds that you hear throughout the lungs that you hear with the stethoscope when you put the stethoscope on the chest wall. If you get some blood work like we did with our last patient, you might get something called a brain natriuretic peptide, a BNP, and it might be very, very high in thousands, for example. If it's over 500, it's very specific for the differential diagnosis that we're about to talk about. And if you can imagine this patient with heart disease, difficulty breathing, we're going to kind of describe this chest x-ray here. So these are kind of fluffy, bilateral, so they're on both sides. You can see kind of the arrows here where they're pointing to. Perihilar, this is the hilum here. And so they're adjacent to the hilum, they're right next to the hilum. And this is kind of a bat wing configuration, or angel wing, if you can imagine. If you can put your hands on the chest x-ray, kind of looks like bat wings. Radiologists like to name things after like food or like animals or like different things. So kind of makes things stick in your mind better. So this is pulmonary alveolar edema secondary to congestive heart failure. So long story short, this is fluid in the lungs secondary to heart failure. Basically, the fluid gets backed up and the heart can't pump that fluid forward. And this patient will likely get treated in the hospital with intravenous furosemide or Lasix, which is a very strong diuretic to kind of help pee the fluid off and help their respiratory status improve. So I'll kind of, since it's been almost an hour already, I'm going to kind of go pretty quickly through all of these. In radiology, we say one view is no views because of this reason right here. So you always want to look at things both on, kind of head on, but also from the side. So another example, this would be an example here, a lateral x-ray. This is an x-ray from the side. This is the same chest anatomy, right? See the spine, the heart, sternum, all that stuff. Sometimes things can hide behind the heart and behind the sternum. And so you can't always see it if you're looking at it head on, right? It might be superimposed. So it helps us kind of triangulate where something might be in three-dimensional space. Again, demonstrating that same point here, one view is no views. And sometimes you can only get one view. In radiology, we also always look at the priors, like what did the patient's prior x-ray look like in order to compare it to the current one. We also see different types of surgical hardware. This is not surgical hardware. These are bra straps. But we can see clips from a patient's prior surgery. Let's say they have their gallbladder taken out or their tubes tied or something. And we can see that as well. So we can see metallic objects as well. So this is a hand x-ray, okay? All the anatomy there for you guys to kind of appreciate. Cervical spine x-ray. Okay, we have a shoulder x-ray here. X-rays are also called radiographs. So this is a elbow x-ray or elbow radiograph. Don't worry about all the anatomy now. If it seems overwhelming, it will come with time. This is a breast MRI and an example of breast cancer. So this is an ultrasound of the abdomen. You can see the liver work very well here. I'm just going through these quickly so you guys can get kind of a flavor for kind of different things that we see, quote unquote see. This is a CT scan of the abdomen, and I'll kind of go through the abdomen in different modalities and different cuts and cross sections here. So of course, the liver sits on the right, the stomach, spleen, and the kidneys. Of course, we have the thoracolumbar spine here, the bladder here. We have some colon. You can see some intestines here, psoas muscles. Of course, the femoral heads. Lots of anatomy. Abdominal X-ray here. This is very good for evaluating kind of the bowel gas pattern. See if the patient has like a small bowel obstruction or a large bowel obstruction, for example. Cross-sectional anatomy of the abdomen again with a CT scan. Again, you see that many of the same structures, and now we can see the gallbladder very well here. So it's colored green, which is nice for us here, and you can also see the pancreas. So, okay, so this is an abdominal. Let's see. There we go. Abdominal MRI. So the MRI looks a little bit different from the CT. So I just wanted to kind of compare that for you guys. So MRI gives us a lot of detail, but of different things, basically, as a take-home message. This is a pelvic MRI. often used to take a look at the prostate gland, for example. Moving on downwards, this is a pelvic x-ray. So oftentimes you take a look at the pelvis as well as the hip. You can imagine like patients can have a lot of problems with their hips, like hip implants and osteoarthritis of the hip, kind of wear and tear. So a lot of things can kind of happen here. And we also get them in the emergency department for trauma cases. Let's say they were in a car accident, because a lot of blood can hide in the pelvic inlet here, like up to like a liter or 2 liters or something. So you want to really look at the pelvis very well, very closely, to see if there's like any fractures or something like that. So we also see a lot of foreign bodies in radiology. This is an example of something that you can imagine kind of where it is. Oftentimes we say you need to clinically correlate, which means that in our report, suggests that we clinically correlate. That means that the physician, the clinician, will have to figure out what this finding on the radiograph or the x-ray means in context of what they're seeing in the patient, because we aren't seeing the patient. We don't know what they're complaining with, what their complaint is, or what symptoms they're having. So I don't think this would actually happen, someone actually saying correlate with the rectal exam, but you can kind of suggest like clinically correlate. And yeah, kind of a meme from a few weeks ago. Hope you guys appreciate this. Fantastic radiology meme account, This Rad Life. Check them out on Instagram. This is an abdominal aortic aneurysm. So this is kind of an outpouching of the blood vessel here. And this is very dangerous because this can rupture and it can be life-threatening hemorrhage. So yeah, just an example of that. Moving on down, we have an example of a disc herniation here. So sometimes the disc can impinge on a nerve. So this is a compressed nerve root, and it can cause kind of shooting pain down someone's leg. You guys have probably heard of sciatica and the like. Now we're at the level of the knee. So you can see a lot of knee anatomy here. Knees are great to look at. The anatomy is like somewhat intuitive. And yeah, you can see kind of some of the ligaments here. Many of you may have injured your ACL or PCL or LCL or MCL. So this is medial collateral ligament, lateral collateral, posterior and anterior collateral or cruciate ligaments, et cetera, and so on. So X-ray anatomy, or knee X-ray anatomy. Now we're at the level of the ankle. Again, lots of anatomy to know: calcaneus, navicular, et cetera, and so on. Sometimes patients don't always know that a broken bone is actually the same thing as a fracture. So if you're talking to a patient as a med student or as a resident, just let them know like it's the same thing if they aren't sure. I was so relieved. The doctor said it was fractured. I thought it was broken. Okay, so now we're at the brain. So it's an MRI of the brain. Just really beautiful anatomy, I think. Kind of same visualization here with same anatomy with different visualization, just kind of colored in. So you can see kind of cerebellum, midbrain, pons, and medulla here, the different lobes of the brain. And we'll get on to these last 2 clinical cases and kind of wrap things up. So this is a CT scan of the head. So this is cross-sectional imaging. And you can see kind of the arrows pointing at something suspicious here. This is a 45-year-old male. Maybe they slipped on ice and had some sort of head trauma, or they got hit by a car or something. And the way we would describe this lesion here, this is a hyper-intense lesion. So it's more intense than the surrounding brain parenchyma or the brain tissue. And basically it's more white, right? Like I think you guys can appreciate that it's more white. It's lenticular shaped. That means like it's lens shaped. That's in contrast to something that may be crescent shaped, which maybe if it tracked along the edges of the bone here, the cranium here. So it's kind of lens shaped. You can see radiologists like their words, and we like describing things. Basically, it helps us arrive at a diagnosis. This is in the left frontal region. So again, this is left side and right side. And then here we have, you can see with this arrow here, we can see a fracture of the left frontal bone. You can see kind of how it's not continuous here. So that's not normal. So bone broken. Differential diagnosis here. You'll learn about this diagnosis in medical school. This is what's called an epidural hematoma. So epidural means it's on top of the dura. There's different layers of brain anatomy. So we have the dura, the pia, and the arachnoid. And this is basically blood sitting on top of the dura, which is the uppermost layer. Hematoma, oma is mass, hema is blood. So, and there are other types of brain bleeds in the brain. There are other types of bleeds in the brain. There's subdural hematomas and subarachnoid hemorrhages and intracranial or intraparenchymal hemorrhages. So you'll learn about these in med school. Okay, last case here. So here we have an MRI scan. So I just wanted to kind of compare MRI versus CT for you guys. So this is a case of a 40-year-old female presenting with blurry vision or double vision called diplopia for 2 weeks. And we can see the arrows kind of pointing at something suspicious. And this patient might also have difficulty walking, maybe off balance or off kilter. And the way we would describe these lesions is they're periventricular. So these are the ventricles in the brain. They're next to the ventricles, so peri, kind of surrounding. And they're kind of globular in shape, right? Not perfect circles, but kind of like globules. And they're foci, so they're kind of focal lesions. And our differential diagnosis here with a patient with these symptoms and in this age range, in this demographic, would be multiple sclerosis. And you guys may know of patients or family and friends with multiple sclerosis. And this we kind of use MRI scans of the brain to monitor their progression because they get what's called these little plaques here, these little foci that we described. Those are called the MS plaques. So I hope you guys enjoyed those cases. Here is a YouTube video of a, well, it's a YouTube video, but it's a super high resolution brain MRI scan of a 58-year-old female, and she died and she had no disease in her brain. So this is just simple normal neuroanatomy. So this is a normal brain. But what's unique about it is that this was published in a research in a journal where they actually took the brain specimen from the patient after she died and then actually put it in a MRI scanner for 100 hours. So they scanned it continuously for 100 hours. And an MRI scanner, in the name, it has magnetic resonance imaging. So MRI scanners have huge magnets. So basically, the larger and the stronger the magnet, the more resolution that you can see in the brain. So you can see lots of resolution here compared to the other scans that we saw. And so they use a 7 Tesla MRI scanner. Other MRI scanners might be like 1.5 Tesla or like 3 Tesla. So just wanted to kind of share this kind of cool kind of research case. If you're still interested in radiology, these are some resources I would encourage you to take a screenshot of. Ben White has a fantastic blog, probably more helpful as a medical student and resident than as a pre-med. Answer is fantastic. It's a fantastic guide as a medical student to match into radiology. This podcast, The Undifferentiated Medical Student, if you want to learn more about IR and diagnostic radiology, he has so many podcasts with other specialties as well, but also I think he has 3 with radiologists, just to kind of get a deeper dive into the specialty. This is a question and answer website, fantastic website, probably more relevant to the residents at the resident level. And then, of course, these are some people on social media who I think do a fantastic job just kind of talking about the specialty and do a great job of mentorship and guidance and et cetera and so on. So in short, people think radiology is easy, but it's not all black and white. There's a lot of gray area. So I'll leave you guys with this kind of tweet here from Dr. Shadowgazer. He's a Twitter radiologist. And, what are all those little lights in the sky that move? And then this radiologist, as a parent, is, well, kid, when a radiologist, dermatologist, or ophthalmologist finishes their intern year, their first year of residency, they package up their stethoscope and launch them into orbit. Isn't it beautiful? So if you're not super enamored with using your stethoscope, that's okay. I'll leave it there, and let me know what questions you guys have. I'll try and answer some of them right now. Let me know, I guess, what case you found the most interesting. Like, comment, and share this video. Subscribe to my YouTube channel as well. And follow me on Instagram and TikTok. Feel free to stay connected. I do check my DMs pretty frequently. And please feel feel comfortable reaching out, because I had a lot of questions as a pre-med that went unanswered. And so just want to be a resource for you guys and kind of pay that back. And in my, never humble opinion, I think radiology is truly the best kept secret in medicine. So, all right. I see one question here. Anything you'd like to add?
Um, I don't think there's any more questions except for the ones that are still in the chat. So you can like go ahead and answer those, and then after that, yeah, I'll just like say some things at the end.
Perfect. Sounds good. What actions are done when there is a foreign object displayed on an imaging screen? Great question. Okay, so well, we'd probably, we dictate a report and then send it off into the electronic ether, and then on the electronic medical record, the I don't know emergency doctor would see that, and then they'd probably have to go fish it out or whatever. Maybe the patient would have to have surgery. It just depends on where it is and kind of how much damage it's doing. Great question. Were there any COVID-19 related cases that you have performed upon? If so, what is it? The answer is yes. I have treated many COVID positive patients. I've treated COVID positive patients who have no symptoms, and I've treated COVID positive patients who died the next day. So, yeah, it's a terrible disease, obviously. The pandemic has, yeah, I won't talk about the pandemic now. And there are a lot of cases of COVID-19 in the radiology literature as well, if you want to look into that. So, what are some notable radiology cases that you have operated on? I'm going to gloss over that question. There are so many different, I wouldn't even call it operating because most of what we do is kind of procedures. Do radiologists typically work remotely or on site to consult with other doctors? Typically, it's on site. You can work remotely. I think maybe 5 or 10% of radiologists work remotely, kind of reading x-rays in their underwear, if you will. Next question is, what aspect of radiology specifically drew you into the field and sets it apart from others? I think I talked about this in my reasons why I went into the field. So I guess go back and watch the video, or pause and take a look at the lecture slides where I kind of detail it out for you. What are some special cases that you found hard? Well, as a radiology resident, as a junior resident, every case is hard. Yeah, nothing unique quite yet. Are there parts of radiology you don't like? The long training can, but again, the residency is long for a good reason. Don't like, some people will say that it's somewhat socially isolating. I don't necessarily feel this way because I feel like our reading rooms at the University of Minnesota are very collegial and collaborative, and like if I have a question, then we can talk about it. And people sincerely take the time out to teach you, to talk to you, and to like get to know you. So I feel like the social isolation part of it doesn't apply to me at this point in my career. Next question is, does the technology used for radiology differ from locations? Somewhat. So this is kind of international versus national. So in certain, developing countries or third world countries, they may not have an ultrasound machine or an MRI scanner or a CT scanner. So there are kind of radiology, kind of global, I guess, brigades, kind of, travel trips where you'll travel with like a ultrasound machine and then go scan patients who have lumps and bumps and kind of figure out what it is and do procedures for them. Like you might be aspirating, like taking some fluid out of a cyst or a possible infection, et cetera, and so on. So you can really help patients that don't have the same technology that we do here. What is the hardest radiology procedure you have performed? What did you learn from it? So interventional radiology probably has the most complex or hardest procedures. You will learn a lot if you do an IR rotation. And if I was to kind of talk about the details of these IR procedures, they'd probably go over your head because a lot of them even go over my head. They're very complex. Some of the, if you want to look up a YouTube video like a TIPS procedure, TIPS, or a Y90 procedure, those are really cool, complex IR procedures that I have personally not actually done, but like scrubbed in on and like been there to observe. So it's very cool stuff. Do you often have to deal with patients that are at risk of becoming unstable during a procedure or a test, like MRI or CT? Great question. The answer is yes. That is typically the case when the patient has some sort of trauma, or if they're a very intensely, very acutely ill, or an intensive care unit patient, an ICU patient, where their physiology is very unstable. But generally, we would not be getting an MRI scan on a patient who is unstable. Generally, we'll be getting a CT scan. So the reason for this is because CT scans take 5 to 15 minutes, and MRI scans can take 30 minutes to an hour. So you can't have a patient in the magnet for an hour if they're going to be unstable, right? It's not good care. What is the best way to practice to understanding reading an X-ray? Yeah, that's the question I'm asking myself every day now. There are books and podcast. Well, not so much podcasts because you kind of need to see books, videos, and so those are kind of the main things. And then practice questions. Practice questions are super important. So the way I study at home is typically with a combination of one of those things. And then we have teaching in the reading room. And then we also have teaching like dedicated lectures during noontime or in the morning on certain days, like 7:30 to 8:30, or like 12 to 1. So the best way to practice is by doing, and so sometimes you just like gotta like open the study and like try it, try your best. And then, like I said earlier, you'll make mistakes and you'll learn from that as well. What are the specialties you work with? Oh, great question. Almost every specialty, if you are a general radiologist, maybe with the exception of psychiatry. It depends what fellowship that you've done. So I'm on musculoskeletal radiology right now, so muscles and bones. And so typically we would be interacting with other orthopedic surgeons, sports medicine doctors, physical medicine and rehab doctors. I was just on breast imaging last month. And in breast imaging, we typically interact with medical oncologists, surgical oncologists, and other women's health providers, as you can imagine. So as a neuroradiologist, you would be interacting more with neurosurgeons and neurologists, right? So it just depends on your subspecialty. Okay, what effect does radiology have on you as a resident? And what small problems do you encounter while performing? And what do you think might fix them? Gosh, it's hard to answer kind of non-specific or generic questions like these. Radiology is my job, so it has a big effect on me, I guess, to answer the first one. That's a hard question to answer. Send me a DM if you want a more detailed answer. What new advancements and new technologies have been developed in the past few years and have improved how you do your job? Well, certainly AI is going to be kind of the next big thing coming around. And it's already actually kind of implemented in certain institutions. Like there's like a stroke AI algorithm that some community hospitals are using. I saw that as a med student. I thought that was pretty cool. Yeah, I don't know. I don't have a crystal ball. It's hard to know what technologies will be available. Do you have to look at a patient holistically? Wow, deep question. Good question. The answer is yes, because we actually have to dig through the electronic medical record to actually read through a patient's chart in order to kind of get a flavor for what this clinician might be looking for, what the patient might have on their imaging. So it's not holistically in the sense that you're asking them about their niece and their nephew and their dog and their cat and their church and their, sleep and their, it's much more targeted to the medical issue at hand. So, of course, lifestyle habits, super important, as you guys all know. Sleep, exercise, community involvement, stress, diet, extremely important. But that is more in the realm of primary care, right? That's not within the scope of radiology. What are some specific skills that you need to be a radiologist that other fields may not require? Good question, and I don't think that there's anything specific because basically before you get to radiology residency, you want to have a really strong clinical background. So the skills that you acquire are really the clinical skills that you will learn on your non-radiology rotations. So if you're learning more about internal medicine and surgery and cardiology, then a lot of the skills will get you so far as like your clinical knowledge, and then you just need like a good clinical knowledge base before you start radiology residency because it's so different from clinical medicine. So there's no specific skills. basically the specific skills are become really kind of clinically strong, so you can understand where the clinician is coming from, where the surgeon is coming from when they're thinking or looking for a certain, or when they're ordering a certain test, right? Because you ultimately need to communicate with them about what the diagnosis is. What advice do you have for upcoming radiologists? Well, none, because I'm still a resident and don't really know that much. How does work-life balance compare in radiology versus other specialties in medicine? Well, it wouldn't be uncommon to work more hours as a attending than as a resident. So you might be working 55 hours instead of 50. But in general, the work-life balance is good. So you might have to work, I don't know, 10 weekends a year or something. But then you might also get like 10 weeks of vacation a year. So I feel like that's pretty good. So it's basically kind of work hard, play hard, which is similar in a lot of other specialties as well. Okay, and I think that wraps up all the questions. So thanks for having me on. Let me know if there's anything else. Feel free to keep in touch. Very flattering of you to have me on. And yeah.
Yeah, perfect. Thank you so much once again. It was amazing to have you on our channel today. And for everyone who's still watching, the Google Forms is going to close at 9:05. So make sure to fill that out and answer all the questions about today's shadowing session to get your hours. And also, we can post the your Instagram and TikTok handle in the chat so that you guys can go follow him. But yeah, thank you so much for being here with us today.
Absolutely. Good luck, everyone. You guys will do great.
Thank you. Bye-bye.